Hello, my name is Elizabeth Kagruder, and I'm presenting my proposal on a fruit and vegetable intervention in pregnant women on substitution opioid therapies. So to give a little bit of information about the background of my target audience and opioid substitution therapies, methadone, Subutex, and Suboxone are the common opioid medications used as substitution treatments for other opioid addictions like heroin or morphine, for example. So it's basically a legal way to go to a treatment center and be monitored and slowly weaned from a more deadly drug. So the population is about 0.4% of the entire world, and opioid users range from 15 to 64. And of those opioid users, 650,000 are estimated to be receiving substitution therapies, even though it's been determined throughout the world that this is the best way to treat opioid addiction. It's still not as highly used. In some countries, it's even illegal. And from a nutritional standpoint, opioid addicts have a higher intake of sweets and lower intakes of fruits and vegetables. They're commonly known to actually crave sweet foods and frequently caffeine as well. They're compared to non-opioid using pregnant women receiving methadone therapy have lower BMIs, they ate more calories from sweets and less calories containing protein and fiber. And also pregnant women using non-substitution opiates have a greater risk of birth complications, including preterm birth, low birth weight, smaller head circumference, and newborn withdrawal symptoms. And I will also say that weaning from one of the drugs like heroin or morphine is not necessarily advised during pregnancy because of the risk of death of the fetus. And also increasing vegetable consumption in pregnant women has been shown to decrease the risk of infants born with small for gestational age. And our target population is women over the age of 18 in childbearing years. And something to be noted of their population per this tip series on how to treat pregnant substance-using women. Most of these women are single parents if they have children already. Frequently, they do not have jobs. And because of those two things, they don't have a lot of resources, so they're at risk of homelessness. And if they're not homeless, the home environment is usually not a stable one. So whether they're bouncing around from a couch to couch of a friend, or they don't have something that is reliable, maybe they're living with a boyfriend sometimes, a grandparent other times, they just don't have a home of their own. They frequently do not have transportation. So something seen is that they'll miss appointments and they do get in trouble because people receiving methadone, Subutex, or Suboxone have to get their medications Monday through Friday. So they have to show up every day. They won't be given doses for the whole week just to prevent any type of misuse. So whenever they are missing because of transportation, that brings us up with the huge problem of they're not getting their medication, and also they're not there for the support from the clinic itself. Then they frequently do not have childcare because childcare has money and most people do not have jobs. Most of these women don't have jobs. And then also they have additional therapeutic needs for things like abuse or special medical disorders. A lot of the times you'll see that there are other needs to go see a counselor, not necessarily for addiction therapy, but because they started to use drugs or alcohol at a young age due to some type of tragic thing that happened in their childhood or something dramatic, some type of abusive situation in young adulthood. So with this intervention, we're going to use the trans-theoretical model and then also the social marketing theory. The trans-theoretical model is ideal for patients with addiction problems because it's a continuous cycle, and individuals can jump on or get off at pretty much any stage at their own pace. So we want patients to go through pre-contemplation, should be they're not really sure whether or not they're going to make a behavior change, to contemplation, where they're really strongly considering it, to determination, they've decided that they're going to make the behavior change, and then taking action on that behavior change. Relapse can happen truly at any time, and that's why this is such an important model for the addicted population, because what's important is not that they relapse, but that they can jump back into action. And then, of course, maintenance. And we want them to maintain any type of behavioral change that we're making, especially within our intervention. So, to also influence behavior change, we want to use dramatic relief with the trans-theoretical model. So we're going to educate women on the negative outcomes associated with poor nutrition during pregnancy. And that would also be some of the things that increase risk because of the fact that they're pregnant using methadone as well. So, for instance, pregnant women who are on methadone therapy are frequently at a deficiency level for vitamin D and also for a lot of the B vitamins. So emphasizing how you can get those things or what the outcomes could be if you don't get those extra nutrients. And then inspiration. So other group members who've started to make healthy choices or healthy decisions, not just from a nutritional standpoint, but their inspiration should also come from the fact that they're doing something about their addiction problem now, so giving them the power to make one more step. They're already in this stage of the trans-theoretical model, stages of change for addiction, so we'll just get them to try to do something else. We're empowering them to feel like they can really get it done. And then self-reevaluation. We want each of these women, to see what it's like to have a healthy baby and how it's going to make them feel at the end whenever their infant is healthy and they can leave after 5 days in the hospital and they don't have to stay and watch their baby after they've been discharged because they're hooked up to all sorts of tubes and other treatments. And then for the environmental perspective, we want to talk to them about how their decisions can influence those around them as well. So choosing to eat healthier, if they have other children at home, is going to directly affect what those children eat as well. So if mom increases fruits and vegetables, chances are the kids at home will too. And then, of course, the fetus in utero, how it can positively influence there as well. And then reinforcement, adding in the home or wherever it is that they are, ways to eat more fruits and vegetables, like keeping them out on the counter and removing things like snack cakes and soda so that they're not tempted to instead have the unhealthy item. We'll also use decisional balance, always trying to tip the scale in favor of the behavior change. So talking about how the benefits outweigh the risk of not changing whatsoever. And then we want to also provide the women with confidence so that they can continue on. So this is again part of sustainability as well. But whenever there's not a program anymore, we want them to feel like they have the tools that they need to get the extra fruits and vegetables. And then also temptation. We want to make sure that we've given them the tools to resist temptation, like not buying the things that are not as healthy. And the social marketing theory goes along with some of these items, but it focuses again on the behavior of increasing fruits and vegetables, and it utilizes the emotional appeal of pregnant women, not necessarily every social marketing theory, but in this particular intervention, we are going to be expanding on that emotional connection that the mom has with the infant. And then also, again, prioritizing the benefit of women enrolled in the treatment clinic. So it goes along with the trans-theoretical model. In tipping the scale, we always want to be talking about the benefits. And then also maintaining an ecological perspective of the intervention along with their treatment. We want to take on the perspective of these ladies. We want to know if they had a hard time getting there in the morning because of their lack of transportation, or if they don't have the resources that they need to have a healthy meal. We want to know those things, so we need to constantly keep their perspective in mind. And then we want to develop the marketing mix And part of that marketing mix are the 4 Ps. So again, the product or behavior is the benefit of eating fruits and vegetables for women and their babies. The price, first talking about the physical price, I included in my demographic data collection tool whether or not these women are on WIC. So you can actually decrease the price of the fruits and vegetables that we're encouraging them to eat by getting them hooked up with WIC. And WIC will also continue to emphasize and encourage fruit and vegetable consumption and contribute to a healthy infant at birth. So the benefits definitely outweigh the negatives in continuing to eat more fruits and vegetables. We're, again, tipping the scale. The place, the treatment clinics are such an effective location because these ladies are required to be there anyway. They have to be there Monday through Friday to check in and get their medication, so this is a really great place to add another intervention. And then for promotion, you can distribute throughout the community at WIC and other public health offices. The local homeless shelter, Union Rescue Mission is what it's called, and other OBGYN offices, because when women are pregnant, they should be seeking some type of medical supervision as well throughout their pregnancy. And then also the Cumberland Treatment Center website. So just getting the word out there for people that are logging on that this is another service that they have available. So my hypothesis is that pregnant women in the Cumberland, Maryland region on methadone, Suboxone, or Subutex therapy will consume at least 2 additional servings of fruits and vegetables daily over a 6-week nutrition education and activity intervention compared to women in the control group. So our target audience, pregnant women 18 years and older, they can't be any younger going to the treatment center. They must be between 8 and 34 weeks gestation. Weekly group sessions will be held for 6 weeks, and they are a requirement for all women who are pregnant going through therapy, unless they have decided not to continue their pregnancy or if they're pursuing adoption at the end. And then each group has 4 to 8 women participating in it, so they're small, which gives you the opportunity to really make an impact and individualize. Our control group will receive the 6 weeks of education. On week 1, they will have the counselor talk about substitution therapies and pregnancy, what to expect. Week 2, a labor and delivery nurse from the local hospital will discuss the experiences that these moms can anticipate. Week 3, an addiction counselor covers alcohol and smoking cessation during pregnancy. Week 4, a lactation consultant will answer questions on breastfeeding. Week 5, the addiction counselor will again cover home safety and infant safety. And week 6 is a registered dietitian there to discuss the nutritional needs during pregnancy, including the increased risk for micronutrient deficiencies. So the control group will receive this education handout from the Oregon Health University, or Health and Science University, I'm sorry. And it does go over MyPlate, and it's gone over in an in-depth manner. We have an hour with the population, but it's just one session over that 6-week period. So the intervention group will have the same 6-week structure and the same speakers at each session. However, after each session, the dietitian will be available to highlight a 10-minute little nutrition snippet at the end of each class. And she'll also be available, he or she will also be available to answer any questions. So here's kind of like an outline of what will be discussed over the 6 weeks. Expected weight gain, drinking more water or milk while decreasing soda, curbing nausea, the benefits of fruits and vegetables, cutting back on caffeine, and then the whole grain benefits. In addition, at the beginning of the class, women will make their own snacks every week, and water will be available at each group. So the first session will be apples with peanut butter, second carrots and cucumbers with a homemade dressing, grapes with cheese cubes, the fourth session ants on a log, the celery, peanut butter, and raisins, the 5th session yogurt smoothies with frozen fruit and milk, And then the last session would be frozen bananas with peanut butter. So giving them ways that they can get